Okay, welcome everyone. We have a varied audience today in several different platforms where this is being transmitted. So thank you very much for joining us from many different parts of the world and in many different time zones. So we'll mention those as we go along. But this is a CME program sponsored by Cinemed. The title of the program is ACS PCI Pharmacotherapy, the expanding role of IV P2Y12 inhibitors. At the end of the program, the folks, those who attended the program, will receive an email from Cinemed, and that's how you will be able to get your CME certificate. Every speaker will share their disclosures during the presentations. However, we also have them on the website along with other pertinent CME information. So without further ado, we're gonna the flow of the discussion today is going to be a case presentation followed by evidence related to the case and why what was done, and hopefully this would put the entire topic in a clinical context for you. So I'm the first person today to show the case. So let me share my screen here. Wow, the host cannot share his screen, and that's not good. Let's see, try again. Okay, I think I have it now.
Yeah, we can
Okay,
see
can
it.
you guys see it now?
We do.
Got it.
Okay, great. Thank you. So this is my disclosure. I'm on the Speakers Bureau for Kaisi Pharmaceutical, and I'm also on their consulting and training bureau. This is about a patient who is a 74-year-old male who had prior history of CABG. His graft anatomy was a Lima to LAD, a vein graft which was sequential to diagonal branch and obtuse marginal branch, and a vein graft to posterior descending artery. So he was seen in the office due to ongoing worsening angina and was brought in for a cardiac cath. On cardiac catheterization, his Lima to LAD was patent. His vein graft, which was sequential to diagonal branch and the obtuse marginal branch, was patent. His vein graft to PDA was totally occluded, and the native right coronary was occluded. And what we found was that he had a severe distal left main disease, as well as ostial ramus disease, and his ejection fraction was still fairly normal. And you can see now this angiogram. This is tight distal left main, tight ramus, OM, whatever you like to call it. The LAD, of course, is occluded. The circ is occluded. So we thought that this is the artery that's giving the patient the most angina. We did do a physiological testing and an FFR of this lesion, and the FFR was 0.64 with IV with just RFR, which is the new Abbott resting indices, which if it's anything less than 0.89 is significant. So this is obviously significant. So we treated this patient with a balloon angioplasty and a 3038 drug-eluting stent. And you can see the stent implantation. And this was the final result. So this patient was loaded with the 300 milligrams of clopidogrel and 81 milligram of aspirin, and it was felt that the result was very satisfactory. The stent was aggressively post-dilated and was sent into the holding area for just observation overnight, and the plan was to discharge him tomorrow. Now I was doing a second case on the same day, and while I was in the second case, I got a call from our holding area that this patient is nauseous, he had chest pressure, and he has some EKG changes on the monitor. So I went and saw the patient. He clearly was having significant recurrent angina and had ST elevation. So we brought him back to the procedure, and now you can see that the distal left main stent is thrombosed, and the whole ramus is totally occluded. So at this point, we crossed this occlusion, of course, and did a Passy's angiojet, to perform as much cleaning of this artery, because we thought there was a lot of clot in this small vessel from stent thrombosis, and a nice flow came back. And then I did an OCT run to determine, what is the etiology of the stent thrombosis. But on OCT, we saw a lot of thrombus, and there was no definite evidence of under expansion. And distal to the stent, there was some residual disease, but it was not critical. And this is what was done after angiojet and additional stent distal to the previously placed stent. And stent was again post-dilated. Patient was given IV Galore, and patient was loaded with 180 milligrams of Tyka Galore. This is the OCT after the second time around to confirm that there was no malapposition or gross under expansion of the stent. You can see that there is a nice apposition of the stent with a very little red. This is a new stent apposition technique with the latest OCT software. Most of you are very familiar with this. You can see that the stent is all white. That means it's very well expanded, and there is no gross malapposition. So there was no definite mechanical cause of stent thrombosis in this patient. So why did this patient thrombose, and whether the patient had inadequate antiplatelet therapy? So to discuss this now, it's my privilege to have Dr. Deepak Bhatt. Dr. Deepak Bhatt is a renowned physician and a keynote speaker of C3 2019 15th year anniversary meeting. He is a senior physician at Brigham and Women's Hospital and professor of medicine at Harvard Medical School. He's also editor of the Harvard Heart Letter. He's published extensively on this subject, and he will now discuss the landscape of P2Y12 agents' efficacy, absorption, and interaction lost in transit.
Well, thank you very much for that kind introduction. Are you able to see my screen?
We hear you and see you.
Excellent. That's a good start. All right. Well, it's great to be here with all of you tonight. And let me dive into this case, a terrific case of complex PCI. I thought the angiogram looked good. I wouldn't have expected stent thrombosis there based on that angiogram. What might have gone wrong? Well, perhaps the platelets were unhappy. And that's what I've been tasked to address here. Before I get started, relevant disclosures include research funding from Chiesi and the Medicines Company, who've been involved with funding analyses from the Champion program. That funding's gone to Brigham and Women's Hospital for my role as the co-chair of the various Champion trials, along with Bob Harrington. So let's start a little bit with this concept of oral antiplatelet therapy. Obviously, oral ADP receptor antagonists are important, a big part of what we do with respect to coronary intervention and ACS, and of course in patients that have got both. What this nice summary slide shows is the pre-treatment data. That is getting oral ADP receptor antagonists on board prior to coronary angiography versus just after the procedure. And as you can see, if one confines the analysis to randomized clinical trials, all the randomized clinical trials of pretreatment have been negative. By negative, I mean no efficacy, but an increase in bleeding. So while it's a common practice, the reality is the data don't actually support pretreatment. Now, obviously, if a patient's going to be parked for several days over a weekend or a 3-day July 4th weekend and not go to the cath lab and they've got an NSTEMI or something, yeah, I would give them an oral ADP receptor antagonist while they're waiting. But at least when times to cath lab are within a day or so, there doesn't seem to be a benefit. That was NSTEMI and stable CAD. What about STEMI? Well, likewise, same story where there's no benefit from pretreatment. Here, there isn't really a safety signal because essentially everybody's going to be getting their ADP receptor antagonist if they've come in with a STEMI. It's just really more a matter of when, but no efficacy from getting it on board a little bit earlier versus later. So this whole concept of oral pretreatment, even under the best of circumstances, is suspect. And part of that reason has to do with time to treatment, as shown again in this nice summary slide. Shown in blue are time to treatment over time in the 2000s, showing time to treatment for STEMI getting a lot shorter. As everybody knows from all the various door-to-balloon initiatives, they worked. We're doing a pretty good job in the US and in most urban areas of the world with respect to primary PCI and rather rapid times to primary PCI. But what's interesting and perhaps underappreciated is what has happened in red. That is, even non-ST signal elevation MI and unstable angina time to treatment has come down substantially from the cure PCI cure days where patients were waiting around with their NSTEMI for 6 days to, in at least high volume urban centers around the world, to a few hours. I know we're taking our NSTEMIs to the lab typically the same day, almost always the next day, even if that next day is a Saturday. So the opportunity for pretreatment to kick in isn't what it used to be anyway, since patients are often going to the cath lab rapidly when they come in with an acute coronary syndrome, either with or without ST signal elevation. And another problem with the oral P2Y12 inhibitors is that a lot of stuff can happen between the time it goes into the mouth and it gets absorbed into the bloodstream. There are issues with drug interactions that have been described, opiates in particular, such as morphine or fentanyl, that can impair gastric transit times, impair absorption of the oral ADP receptor antagonist. So that's a real issue, especially in patients coming in with ACS, almost all of whom, at least in US practice, are going to get intravenous opiates. And for sure, if someone's coming in with crushing chest pain, it's hard to not treat that pain. Even in the elective situation, most US labs I've scrubbed in are giving a combination of benzodiazepines and intravenous opiates for the sake of patient comfort and sedation. So that's a real issue. You know, might things like crushing the ADP receptor antagonists make a difference? Well, Dr. Gibson will address those issues. But, you know, I can go through all the data, except I don't have time to go through the data. So sometimes a picture is worth 1,000 words. And this is from the cath lab of Dr. Gibson and Dr. Pinto, the BI here in Boston. And you can see here a successfully recanalized STEMI patient, beautiful angiographic result. But what's not so beautiful is the 2 300 milligram tablets of clopidogrel still sitting there in the gastric fundus at the time of the completion of the procedure. So a lot of times when we're pre-treating patients, it's successful pre-treatment of the physician and their anxieties, but not really the patient and their platelets. So potentially then an intravenous agent, Galore, fits the bill where an ADP receptor antagonist is delivered quickly in intravenous form. And the properties of Kangol are such that it's got a very fast time of onset as well as a fast time to offset. And that seems to be the exact property we'd want for patients coming to the cath lab about to undergo PCI. And since a picture can sometimes be worth 1,000 words, on the left-hand panel here, you can see a thrombus forming. This is a mouse cremaster muscle. I'm not sure who actually is doing that type of research, but at any rate, if one looks at the mouse cremaster muscle arteriole, on the left-hand panel, you see a thrombus that's forming there without anything on board. On the right-hand panel, with Kangol on board, where there's still a little bit of thrombus forming at the site of endothelial injury, probably a good thing. You don't want people bleeding out. But on the other hand, it's not an occlusive thrombus forming. So the properties of Kangol are shown here in an animal model certainly seem to be favorable. But that's animal model. Let's talk about human models. And the Champion Phoenix trial was the pivotal trial for approval of Kangol for use in patients undergoing PCI. And the specific population was almost 11,000 patients, essentially all-comer PCI, stable angina, non-STEMI, STEMI, that were P2Y12 inhibitor naive, not receiving an intravenous glycoprotein 2b3 inhibitor. But other than that, it was pretty much an all-comer trial, and patients were randomized to Kangol bolus and infusion versus placebo. And the primary results have been published in the New England Journal of Medicine. Gregg Stone and Mike Gibson on the panel here are part of the executive committee of this study, and the primary endpoint of ischemic events at 48 hours significantly reduced with Kangol versus clopidogrel loading on the table. Stent thrombosis, the pre-specified key secondary endpoint, was also significantly reduced, essentially cut in half. So both the primary and key secondary endpoints met. Now let me just discuss bleeding. The primary bleeding endpoint, gustosevere bleeding, no significant difference. No significant difference in transfusions. Really the only difference was in acuity major bleeding, and that was largely consisting of groin hematomas in excess with Kangol versus clopidogrel. As far as really bad forms of bleeding, no significant difference between the two randomized treatment arms. For the sake of time, I'm not going to go through every subgroup other than to say all the important subgroups that were pre-specified and examined. The drug looked good versus the comparator arm. This included if one used a 300 milligram loading dose, as has been validated in the initial pivotal trials and initial labeling of clopidogrel, or if one uses the 600 milligram loading dose of clopidogrel. Also true whether the load was given before the start of PCI or after the start of PCI. And sometimes people wonder, do the results of these large international trials apply to my practice? Well, we had a lot of sites in the US, great sites, I would say, and the results apply in the US. That is, the results really, in a statistical sense, were consistent in both the US and non-US subgroups. If anything, numerically speaking, looking marginally better, not worse, in the United States. And likewise, looking at femoral or radial access, looking at males or females, we see that the benefits of Kangol are consistent in key subgroups. Now, another thing that was examined in the trial was intraprocedural stent thrombosis. This work was all done in the core lab of Dr. Stone. And basically, the bottom line here is intraprocedural stent thrombosis reduced consistently across subtypes of inclusion, that is stable angina, non-ST elevation ACS, and STEMI. Well, sometimes physicians say, this antiplatelet therapy stuff, yeah, it's preventing CK leaks. Who really cares about that? In fact, it wasn't just small MIs prevented in Champion Phoenix, it was big MIs as well. In fact, there was a larger proportional effect on the big MIs than on the little MIs. Now, there were more frequent little MIs, but even if one is confining the analysis to really big MIs, like 10 times the upper limit of normal, nobody's going to say that's a trivial event. There was a significant reduction. And we looked at all sorts of different definitions, sky definitions, and so forth. Consistent benefit, however you slice the pie. That's Champion Phoenix in a nutshell. The Champion program was much larger with 2 preceding trials as well, 25,000 patients in total, slight differences in design. Bottom line is shown in this meta-analysis published in the Lancet, really a consistent benefit. If you look at stent thrombosis as an endpoint, cut almost in half. If you look at hard endpoints at the bottom here, death, Q-wave MI, ischemia-driven revascularizations, blinded trial, cut by about a third. And in the accompanying editorial in the Lancet, Shamir Mehta commented that Kangol was a new champion for percutaneous coronary intervention. I agree. Yeah, apropos to the case that Dr. Dave just presented, there's data from Champion platform that may not totally be in people's consciousness anymore, but these data were published in the New England Journal of Medicine. And you'll see the overall trial didn't meet its primary endpoint. We had a definition of periprocedural MI that just created a lot of noise. It was a bit too sensitive. In fact, measuring all those CK leaks worked against us. But what is interesting here is if one looks at the secondary endpoints, pre-specified hard endpoints in a blinded trial, there was a significant reduction in stent thrombosis and in all-cause mortality in patients randomized to Kangol versus placebo. In this case, the clopidogrel was given at the end of the trial. So this is really largely aspirin, anticoagulant, mostly heparin, and patients then randomized to Kangol versus a placebo infusion. So this gives the cleanest assessment of what potential Kangol and potent antiplatelet therapy has, reductions in stent thrombosis and in death. The event rates, of course, are infrequent in this particular population, but nevertheless important events when they occur. A few final points I want to make from the Champion program. We also did have some patients that were treated with 2B3 inhibitors in the trial program, and this basically examines those patients who received or did not receive 2B3 inhibitors, and then looks at the randomization to Kangol or to clopidogrel. So essentially looking at those without and those with 2B3 inhibitors given. In either case, it turns out that Kangol beats the control arm, but there was no added benefit to there being a 2B3 inhibitor on board. In fact, it was just associated with higher bleeding, regardless of whether the randomization was to Kangol or clopidogrel, and consistent with other data sources as well with respect to 2B3 inhibitors and bleeding. So those are randomized comparisons. We also did, within the context of the large Champion program, a propensity matched analysis of patients receiving Kangol versus 2B3 inhibitor. Again, this part wasn't randomized, it's propensity matched. There's no randomized clinical trials looking at clinical endpoints of adequate size to really say anything. And this pulled the data from all three of the Champion randomized trials. And here's the bottom line. In terms of ischemic events, an odds ratio of 0.79, numerically in favor of Kangol versus clopidogrel plus 2B3 inhibitor, though the p-value wasn't significant. Though if you look at stent thrombosis as well, an odds ratio of 0.17, again, a small number of patients relatively that we could match, the p-value is not significant. And bleeding was lower, and blood transfusion, in fact, was significantly lower, about 50% lower, 2 versus 1%. So what you get essentially when comparing Kangol versus clopidogrel plus a 2B3 inhibitor is at least similar ischemic benefits, maybe better, and a lower adjusted risk of major bleeding. Again, with the caveat that this isn't a randomization, but a propensity match. So to conclude then, I would just say with respect to what we learned from the Champion program, Kangol during PCI significantly reduces ischemic events, including the primary endpoint of death, MI, ischemia-driven revascularization, stent thrombosis, significantly reduced the secondary endpoint of stent thrombosis, as we saw occur in the nice case that was just presented, significantly reduces intra-procedural stent thrombosis as assessed by a blinded core lab. And as I mentioned, this core lab analysis led by Dr. Stone, the largest core lab analysis done to date in interventional cardiology, and he'll come back with some more specific angiographic analyses that he published in EHJ later on this evening. Kangol was shown to consistently reduce important ischemic events, irrespective of the MI definitions that were used, and including hard events, data I alluded to but didn't actually show. So Kangol really is superior to clopidogrel across the full spectrum of PCI in reducing important clinical events. And there's really nothing about Tyka or prasugrel in this situation that would change the fundamentals shown here. Well, thank you very much for your attention.
That's fantastic, Deepak, as always. Let's open it up for discussion. Any other panel members have any suggestions about what they could have done with the case after listening to what Dr. Bhatt had presented and what you saw on the angio? Bryan, you are a clinical practitioner in a huge facility. What would you do in a case like that?
I think, Raj, I would have done the same thing. You know, the times that this happens to me, I kick myself for not using it. I use it in virtually every STEMI that I do, and in high risk, in patients that I think I can anticipate a high risk non-STEMI. But I think that's the point, is sometimes you can't anticipate. And I think that's what happened to you. I think you were not necessarily anticipating that this was going to be an issue, and then it was. Dr.
Gibson, your mic is on mute.
No, yeah, that's the story of my life. Thanks. But I've seen the same. I mean, I've seen that same angiogram happen to me, but it was really when someone was vomiting after a procedure. And a statistic that I hunted around for, and I was surprised to see, is about, I think it's up to 15% of people with ACS will vomit. And we often don't realize it, and it can happen after the case. You know, things went great in the lab, and then the person's out in the holding area, and they start, you know, expelling all the contents of those things sitting in the stomach. So this happens. The other issue is, a lot of times we use full dose aspirin, the full dose non-enteric coated aspirin rather than the 81, just to make sure someone gets, full aspirin on board. But this happens to all of us.
Yeah, it was interesting. You were mentioning anecdotes. It happened at a great time. For me, actually, there was Kangol was being debated whether it should be brought on the formulary. Obviously, I was recused from the discussions, but the head of pharmacy came down to the cath lab. I was in the lab the day, I guess, they were debating, and he said, this stuff's kind of expensive. Do we really need to get on the formulary? Why do we need it? And it was terrific because we're sitting there, and if you've ever been to the Brigham, it's sort of a fishbowl-like series of cath lab rooms. And in the room, sort of opposite where we were sitting in the middle, Laura Maury is whisking back a patient. This is before she went to Medtronic, whisking back a patient, a guy in his 30s, insulin requiring diabetic, had come in with an inferior STEMI, got Tyka loaded, but in the holding area after the procedure, nauseous, vomiting. I guess the Tyka comes up, stent thrombosis, he's back in the lab. And I said, look, that's why we need to have Galore on the formulary. So yeah, it happens. It happens in the best of hands. Even if the technical result's perfect, even if you're using IVUS and OCT, high pressure inflations, and all the latest toys and tools, sometimes the platelets are still just going to be angry. Sometimes patients aren't going to be absorbing for any variety of reasons, even if we're using advanced antiplatelets like Prasugrel and Tyka, even if we're crushing them.
Another point, Raj, that people aren't aware of, and I always ask this at symposium, are people aware of the change to the FDA label that says if you are giving narcotic analgesics, you should consider, that's the language, you should consider the use of a parenteral antiplatelet agent. I think one of the greatest contributions I made to interventional cardiology was that picture of the pills sitting in the person's stomach. I actually gave my life to cardiology. People doubted it. They didn't believe it was clopidogrel. And Dwayne, I put clopidogrel tablets on my stomach and he filmed it. And it's true. They're just sitting there not getting absorbed. So people don't realize everyone gets fentanyl, in our lab at least, and there's a lot of delayed absorption. So I think people need to think about that. And the FDA certainly, for all three thienopyridines, has given us that warning in the label.
Yeah, does that mean that I can make my my mark in cardiology by showing the clopidogrel and the emesis basin?
You could, yeah.
There it is. It's a shot.
Yeah,
I think I'm most paranoid about the out of hospital cardiac arrest patients that come in as a big ischemic presentation. An OG tube has gone in. You have no idea what meds or what timing those meds were given in. Presumably the antiplatelet therapy is in there. Occasionally it gets crushed, but usually it's pretty much a fire drill. And I think that those are the patients where there's a really big question mark as to what degree of antiplatelet therapy or even anticoagulant therapy. Some of these folks come in with IVs that I'm just not all that certain about. So those are the cases, the very high risk cases that we end up using almost routinely.
Raj, I was going to ask you, I was like Deepak, surprised at the stent thrombosis here. I don't think any of us would have expected it. And this was not a troponin positive patient. Is that correct?
No,
this was
it was a patient that was seen as an outpatient worsening angina and was brought in as an outpatient. And
right.
Because the patient was outpatient, he was not loaded on any antiplatelet therapy. He didn't have non-STEMI or STEMI.
Right. So he was on nothing, not even aspirin?
He was on aspirin.
He was on aspirin, but he didn't get the clopidogrel until after the procedure.
Correct.
Right. So, and he got what, 300 or 600 milligrams of
He got
clopidogrel?
300.
So 300. So we know that's 6 to 12 hours to really get active. And so he was still, you said it was about 4 to 5 hours. He was within that window when he basically had only aspirin on board for all practical purpose. Right. And of course, depending on race and ethnicity, anywhere from about 18 to 30% of patients are hypo-responsive to clopidogrel. And, as many as 10% may actually have almost no clopidogrel metabolism based on CYP2C19 loss of function alleles. So it would have been interesting if you had ever had a chance to get blood and see if he responded. Obviously, when he has the stent thrombosis, you're going to, respond with a potent parenteral agent, as you did appropriately. I was also interested, and this will be vis-a-vis the later cases though, looking, given that the patient was troponin negative, putting on my interventional hat and looking at that lesion. It wasn't a straightforward lesion. You know, and in fact, there was some length to the lesion, but it also looked fairly hard. I don't know if it was fibrotic or calcified, not seeing the OCT ahead of time. There was one area that looked like it was a little bit underexpanded.
Yeah,
and,
at the curve.
at the curve. And it was a bifurcation of sorts, you know, not a major bifurcation, but a bifurcation of sorts. So it gets into, you got a progressive angina, troponin negative, okay, but, you know, the guidelines say, you know, you can load after the procedure. You don't have to load before the procedure. So you followed guidelines here, but you still end up with a stent thrombosis. And it'll get into, again, with some of the data I'll show later in the second case, as to when we should consider ensuring that the patient is adequately loaded on the table with a parenteral agent like Kangol. In retrospect, do you think you would have done anything differently?
I think that the only thing that, you know, now I think that we have become so much more liberal with the Kangol use, that if we see lesion complexity, if the patient is not preloaded, our threshold of using Kangol is very low. Instead of clopidogrel, pretty much have, you know, moved on to the second generation anti-platelet drugs such as Tyka, Galore, and most of these patients. But our Kangol use has gone up exponentially, you know, since I've in fact, you know, if I remember this correctly, when Deepak and I did this session in 2019 meeting, I showed another case of LAD stent thrombosis, so the patient actually ended up not doing well. And that patient had IVUS guided LAD stent implantation extremely well, implanted stents in the LAD, and was given, in fact, Galore. I became very nauseous during the procedure, had a whole bunch of Versed and fentanyl, and within an hour having a huge stent thrombosis, and turned into quite a substantial disaster, required impella, you know, we did all kinds of stuff, and then the patient ultimately didn't do so well. So I think that our Kangol use has substantially gone up. We don't have F6 in our lab anymore because the institutions decided to not have that. The only only TB3A that's available in our lab is FT5-tide. We find that, you know, besides, you know, the data that Deepak shared, we find the use of Kangol is so much easier. That can be given very quickly. We can turn it off if there is a problem with the groin bleeding or anything like that. So we find it very convenient to use it. And that's part of the, also our motivation to be liberal with it.
Yeah, you know, I'm glad you showed this case because, you know, a lot of times I hear interventionalists say, oh, you know, I never see stent thrombosis in my practice. And, you know, I guess that's good, but, you know, it's an infrequent event, obviously, in the current era with, you know, low profile stents and good implantation techniques and so forth. But it happens in the best of hands, and it's infrequent enough that you might not see it. I mean, if you're doing 100 cases a year, you may not see it. But, you know, every time we look at the large randomized clinical trials, the registries, you know, it's there, and the consequences are pretty significant. So I think that it's important to do what we can to minimize complications in the cath lab, including stent thrombosis.
Okay, great discussion. Thank you very much. Let's continue with the program. And now there is another clinical issue that is, you know, all of us face, is that we do get patients in a transfer for STEMI intervention. So my very good friend and C3's course co-director, Dr. Bryan Kluck, who is a very senior interventional cardiologist at Lehigh Valley Network in Allentown, will now share a case of acute MI in transfer with us.
I hope I can get this to work, huh? Share.
It's a lot like Bruce Springsteen to me.
Now be quiet there, Clarence. Let me go back.
We can see it. Yeah.
Good. Okay, so as I said, right to the meat of the matter, this is something that happens quite often to us here. My disclosures are at the beginning. I speak for Kayesi, no other disclosures. This is a 71-year-old gentleman with no prior cardiac history. He's a smoker. He last saw his only doctor, his PCP, 10 years prior, and he lives in Florida. He was visiting relatives in Hazleton, PA. Hazleton, PA is 45 miles, a long 45 miles from our center. He developed crushing substernal chest pain, diaphoresis, and nausea. His hemodynamics were stable and okay. This is his subtle electrocardiogram. And I'll stop at this point to add one feature in addition to absorption and narcotics and differential effect. And that is that we're forced to have a conversation with the ER doctor at the sending institution. And about 20% of the time, even though I tell them what to do, they don't do it. And so there's always a question about whether or not the patient got the medicines that we loaded them with. I would ask you why I have to call them if they're not going to do what I do, but anyway, this is the EKG. He was helicopter transferred to our institution. From Hazleton, you have to actually drive from the ER to the airport to then get the helicopter, so it's not actually that much of a time savings. His hemodynamics did remain stable on transport, and on arrival, he got aspirin, he got heparin, he got 600 of a clopidogrel. In the lab, he got a Kangol bolus and infusion. He got a ticagrelor crush. This is his left system. This is his right system, and my sense is that there's a kind of a leading edge of thrombus there. There was a little bit more flow with the wire through it. And this, not on every case, but there's a little bit of thrombectomy going on here, followed by the appearance of what I thought was more thrombus, and so more thrombectomy. And at this point, I've presented this case at another venue, and people asked why I didn't do more thrombectomy. But at this point, early in the morning, I thought this was about the time to see if I could make a highway. I thought the flow was a little slow here. And I think it picked up there. There might have been I think there was a little adenosine at that point. This is our final outcome. This is his echo pre-discharge. He remained asymptomatic. His A1C was subtherapeutic, so to speak. His echo I showed you. And then the final issue, unfortunately, was that he was transitioned by the hospital medicine team to clopidogrel based on cost and without consultation to cardiology. That's my case.
Great, thank you, Bryan. So now it's a privilege to introduce Dr. Michael Gibson, who is Professor of Medicine at Harvard Medical School and CEO of BAME Research Institute. Is a pioneer in the field of cardiology. He was keynote speaker and award winner at C3 2019 program, and he's been a leading investigator in multiple trials related to acute coronary syndrome. And he will now discuss crushing oral P2Y12 agents, lessons learned from Kentic trial.
Well, thanks, Dr. Deve. Thanks for having me back. You put on such a great course, and it's so great to be back with you. And I actually find these sessions a lot of fun that we've been doing in the evenings. So I'm going to talk about the Kentic study. My disclosures are shown here. I receive a lot of research grant support from every major manufacturer of antiplatelets and antithrombins. So the study was published by Dominic Angelillo and his co-workers A lot of people have said, well, you know, why do I need Kangol? I mean, that study, that was back in the days of clopidogrel. And I do things differently. I load in the lab with prasugrel or ticagrelor, and I have the patient chew it. Well, this study was designed to answer the question, at least for ticagrelor, whether that offers as good a pharmacodynamic results. Obviously, Kangol is fast-acting, it's intravenous. Ticagrelor is good and quick, but not that quick. And what they did is they looked at how quickly the different drugs act at the time of the procedure. They did a very nice job. It was prospective. It was a randomized study. It was double-blind and placebo-controlled, and they looked at a total of 50 patients. Their primary endpoint was to look at the platelet reactivity units, that's PRU, 30 minutes after they gave the drugs, and a lower PRU is good, meaning you had lower platelet reactivity units. So you had STEMI patients come in, they got randomized 1-to-1, half the people got crushed ticagrelor, and with a placebo given IV, and the other half of the people got crushed ticagrelor with Kangol. So everyone got crushed ticagrelor. The only difference here was whether you got Kangol or not. And did the addition of that Kangol improve that 30-minute platelet reactivity units? The flow is shown here. They had, you know, good compliance with the protocol. And here are the results. No surprise, really. Again, everyone got ticagrelor. What we're looking at here in green is the Kangol results, where you see it knocks down platelet reactivity units really promptly, really potently. And the third P for me is predictably. The potent part is the lower number. The prompt part is that rapid fall. But what's the predictable part? The predictable part is here. It's the standard deviation of that PRU. So notice that the error bars around the green are smaller, meaning that you have a more predictable response compared to the blue, which is ticagrelor alone. So it really satisfies the 3 Ps for me. It's more potent, it's more prompt, and it's more predictable. So you can see at 30 minutes, it's better. At the end of the PCI, you had better inhibition. 2 hours afterwards, you had better inhibition. It's not until 1 hour after you turn the Kangol infusion off. That's 1 hour after you turn the Kangol infusion off. Then the two strategies are the same. So you have to look at that kind of area between the two curves as a vulnerable period, and you have better results with Kangol. This is when you, instead of looking at PRU, look at PRI, a similar measurement with VASP. Same story, different assay, different reality check here. So we have 2 assays giving us a similar result. Well, the other thing I want to point out is over here on the far right, where it says absence of DDI. DDI is drug-drug interaction. There are a lot of people out there who are very worried about Kangol. They said Kangol is nothing but a thionopyridine inhibitor. You know, when it binds to the platelet, the other drugs can't get on. But that's not the case here. You can see that there is no difference whether you got Kangol or not in the platelet inhibition. It's not as though it made things worse for the other arm. This is, again, just the individual data. I think it kind of highlights the more consistent response as well as the more rapid response. Again, this shows, again, more consistency or predictability of response in green compared to blue for VAS. So any way you cut it, you had better results. So Kangol is more prompt, it's more potent, it's more predictable. You know, we are so quick in the lab these days doing these cases that you have to have something acting almost immediately, and it does act as early as 5 minutes. It's better in all these measures than crushed ticagrelor alone. As I said before, 15% of ACS patients are going to vomit, and even if they successfully swallowed that crushed ticagrelor, it may come back up. And really the results were very consistent when you use two different assays, so very, very consistent results. So I think this supports what the FDA in particular is saying in the label for the thienopyridines. In particular, if you have received an opioid as part of the procedure, you're going to have even more delayed absorption. Doesn't matter whether it's crushed, doesn't matter if it's a pill, you're going to get delayed absorption. And for that reason, the FDA does say you should consider a parenteral antiplatelet agent. And I think this shows you, the reasons why from a PD perspective, how's the drug really working perspective, why this may be better in terms of potency, speed, and predictability. So that's all I had tonight.
Thank you very much, Dr. Gibson. We'll open it up for a discussion. We have one question from the audience for all the panel members. Would you have considered giving a 2B3A like tirofiban in a patient that Bryan received at the hospital? Or would you prefer Kangol over tirofiban?
But the questions to me, I like it because I like Kangol better because its onset is so rapid, and so is its offset. I think it's a very controllable. Nothing that I think starts with a P that you could make that would define controllable, but it's under my control. If for some reason I don't load with another agent and the patient should have to go to surgery, the agent is gone in a short period of time. And I'm not really sure that the data, which I think was generated mostly many years ago, with different dosing, is being applied to how it's being used here in the United States today. And I have an issue with that.
Gregg, I think you were supposed to say something. Yeah.
Well, no, I mean, I would agree with that. And, in addition to the controllability, I think, very important is the rapid offset. If you start getting any bleeding, you turn it off, and in 30 to 60 minutes, the antiplatelet effect is gone. And, in the older days, when we did the large trials, of course, of 2B3A inhibitors versus control, we had increases in major bleeding, not only minor bleeding, not only hematomas, but also increases in major bleeding, as well as thrombocytopenia. And with Kangol, perhaps because of the rapid offset, you can convert what might have been a big bleed into a very small bleed. So as Deepak showed you, in none of the trials did we see increase in major bleeding. We just saw increase in local femoral hematomas. And of course, with the move now towards radial intervention in the majority of the patients, even the hematomas are going to be gone. And thrombocytopenia is also something that we've not evidenced with Kangol. And then finally, although we have no head-to-head trials of Kangol versus 2B3A inhibitors in terms of effectiveness, you saw the data that Deepak showed, which suggests it's at least and possibly even more effective, and it has an efficacy effect beyond 2B3A inhibitors, at least in that propensity-adjusted analysis. So I think for all those reasons, for me, Kangol would be the agent of choice at this time. We know that both acute MI and stent thrombosis, it's really platelet mediated, and it's really the ADP receptor that's at the heart of the activity of both acute thrombus formation and PCI-induced complications. And that's why I think the targeted P2Y12 inhibition that you get from Kangol as opposed to 2B3A inhibitors, which of course block the final common pathway of platelet aggregation, to me, blocking activation of the P2Y12 receptor gets more to the heart of the problem without having those excess side effects.
That's fantastic.
I agree.
Yeah.
Oh, no, I was just going to agree with everything that Gregg just said. I think, you know, the short offset time really is an advantage if you run into bleeding complications. And I think it's that flexibility that makes it very friendly to the cath lab. And it's not that I don't like 2B3 inhibitors. In fact, I was involved with a lot of those early trials and, you know, think the data are great when the comparator is 2B3 inhibitor versus placebo. But I mean, there really was an interventional sort of a series of trials that advanced the field, you know, with bivalirudin, replace 2 acuity horizons, showing that you could get similar benefits but less bleeding. So it seems like almost going backwards in time to then say, now let's add the 2B3 inhibitor back on board. It's like we didn't learn anything at all from a series of trials over several years. And, you know, for the sake of time, I didn't review it, but, you know, in the Kangol program, we had patients who received bivalirudin. We had those who received heparin. Harvey White's published this work, and, you know, the drug worked equally well in both those circumstances. So whatever your preferred anticoagulant is, it does appear that you can add Kangol to that safely and effectively.
There is one more question. The data with glycoprotein 2B3 inhibitor and bleeding is with long duration of infusion. What about a 2-hour infusion of glycoprotein 2B3A? Would you be still concerned about bleeding, and would you still choose Kangol?
Who knows?
Well, you know, it just, as you say, it just hasn't been studied in a large number of patients. And the offset of the 2B3A inhibitors, particularly the small molecule 2B3A inhibitors, is prolonged, you know, up to 12 hours. And yes, you can reverse that with platelets, but it still has a very prolonged biologic half-life. So, we just don't know about the effectiveness of either bolus only or bolus plus short infusion. Be great to see I'd love to see a large head-to-head randomized trial of say Tirofiban versus Kangol. I think that would be fascinating.
Yeah, I agree. But you know, ideally it'd have to be powered for clinical endpoints. I'm not sure,
Right.
You know, just looking sort of at surrogate platelet markers.
Oh, absolutely, of course.
That much. But I'm not sure anyone's going to do that sort of large, expensive trial. But absent that sort of data, I think, as Gregg said, the disadvantage of the 2B3 inhibitors is the long onset time. So even if you just do a bolus-only strategy or a bolus in a couple of hours, it's still going to linger in the system for several hours. So if you run into, you know, femoral hematoma, if you're doing a complex case or using mechanical support or something like that. Or, you know, we learned from really a number of trials, including, you know, trials like Horizon Acuity, it's not just groin bleeding. Even if you're doing all radial, and of course you have to do femoral for certain things like mechanical support, but even if you're doing predominantly radial, you know, GI bleeding, for example, or GU bleeding can rear their ugly head. So, you know, there's all sorts of unexpected bleeding that can occur, especially in older patients and sicker patients. The advantage of Kangol is that it does have a very short offset time, unlike the 2B3 inhibitors, and shortening the infusion of the 2B3 inhibitor doesn't eliminate that issue.
The fourth P, Raj, is persistence. So the 2B3 inhibitor has persistence, where you don't have that here with the Kangol.
Yeah, in my lab, you know, for years we used to do short infusion and just bolus only 2B3 inhibitors, but we had substantially more bleeding clinically, you know, at least in, you know, almost 20 years of my interventional practice in comparison to what we see with Kangol now, you know, with the drug is pretty much gone in an hour after it stops. So it makes a big difference in, especially practice like ours, where we use a lot of atherectomy devices, a large number of peripheral procedures, a lot of femoral access. And in talking about mechanical circulatory support now, you know, it's we'll keep the program moving. We'll have some more discussion about this. Now I'd like to invite another course co-director of C3, Dr. Sandeep Nathan, who is the Associate Professor of Medicine at University of Chicago. He's very well published in area of acute coronary syndrome and mechanical circulatory support. And he's going to share with us the third case where the issue related to Kangol comes up, planned, complex multivessel hemodynamically supported intervention.
Okay, Raj, thank you so much. It's a great pleasure and privilege to share the panel with such distinguished speakers. So the first two cases were acute stent thrombosis and STEMI. We're going to transition now to a complex patient who's ostensibly more stable at the outset. So here are my disclosures. Okay, so this is an 86-year-old gentleman who initially had a nuclear stress test for angina, revealing anterior and infralateral ischemia and a lateral wall fixed defect. His EF is about 20 to 25%. An angiogram was recommended. He was sort of mulling it over. But 2 months later, he was admitted with hydronephrosis and then subsequently had a VF PEA arrest during a urology procedure. By some stroke of luck, he was resuscitated and stabilized, and he underwent a cath revealing obstructive three-vessel disease, and the recommendation was appropriately made for CABG, which the patient declined for personal reasons because he was the sole caregiver for a family member and simply felt that he couldn't be out of commission for so long after bypass. So he was referred to our institution for complex supported PCI. Some other relevant data, PAD, severely calcified right iliac stenosis, was discovered in the context of his diagnostic angiogram. He has a history of treated CLL in remission, diabetes, CKD3, and a left bundle. So after the CABG was declined, the patient was started on DAP, aspirin, and clopidogrel. And the clopidogrel was a deliberate choice considering his age and bleeding risk. I think that understandably, there was a little bit of discomfort with putting him on a more potent oral P2Y12 inhibitor. And some weeks went by with the patient remaining stable. He was admitted the day before PCI for fluid optimization. And I added on a P2Y12 assay, a Verify Now assay, since he came in on clopidogrel, and the decision was made by his primary team to put him on clopidogrel. Just for curiosity's sake, we ordered that. So what you see here on the angiogram is, as you can see for yourself, he's got osteal 70 to 80% left main disease, a diffusely diseased LAD, 70 to 80% osteal disease of a dominant circumflex. He's also got 90% lesion in a medium-sized OM2 branch, which we thought perhaps mapped out both by wall motion and perfusion to an area that was infarcted. Some very calcified right common iliac artery stenosis and moderate disease of his abdominal aorta that you'll see here. Another view, you can see that circ lesion right at the ostium, very large vessel, and then diffusely diseased LAD. And then the last image is the best image, I think, of the peripheral disease. So some added challenges. You can see that the distal aorta tapers. So the access plan was ultrasound guided bifemoral access. He had his diagnostic angiogram, as you can see, from a radial approach. He didn't love that because of some spasm and some arteritis afterwards. And so he requested a femoral approach for this. And we thought that we would support him with an Impella, but in order to do so, we'd probably have to do a little bit of work on the periphery. You can't fully appreciate this on the DSA image, but there's quite a bit of calcium in that right iliac, and so we decided to do IVL with shockwave to that side, use that for a 7x45 destination and get a 7 French EVU past that, use the left side for an Impella plus minus shockwave if there was more disease than we saw on the angiogram. So here we go, unfractionated heparin anticoagulation, shockwave IVL. We got clean bifemoral ultrasound guided access, glide wire and trailblazer, swapped out for a Spartacore, and then a 7x60 shockwave balloon positioned across the right common iliac. 10 rounds of 30 with a very satisfactory resolution to the lesion, at least enough to get a sheath past it. And then we get on to the coronary work. I was pleasantly surprised at how easily the dilator went up the left side, and so we didn't bother to do anything with that. We just put a CP past that and got to work. Now, shortly after we started wiring, the P2Y12 platelet inhibition assay resulted at 255s, and we had ordered it the night before. Unfortunately, the sample had clotted. It got sent off the morning of, and it resulted in the middle of our case at 255, which I think most people would agree is not really a therapeutic response to clopidogrel, despite the gentleman being on clopidogrel for a couple of weeks now. And so we made the decision to give him Kangol, and I think it touches upon a lot of the important questions that were raised in the chat about bleeding and so forth. We've got a lot of access in here. We've got an 86-year-old gentleman. There's many opportunities for this case to derail. And so if it's going to derail, at least we have the benefit of some reversibility. And while we're doing some fairly heavy-duty work in the coronaries with a reduced EF, we are relatively well protected. So the Impella worked great. 3.4 to 3.7 liters per minute with significant loss of pulsatility as the LV was unloaded, but the MAP stayed at 70 to 75. And here we go. LAD PCI was performed first at 2.5 by 34 onyx at 16 atmospheres. And then the circ was wired. The ostium was dilated with an NC balloon. We thought we might have to rotablate that and lose control of the LAD for a minute, but that opened up pretty well as well. And then we dilated the ostium of the left main. 3.0 by 12 onyx stent was positioned at the circ ostium. The plan was to, we kind of kicked this around whether we should do DK crush or how we should do this. We said, okay, let's just, we've got enough variables here. Let's try to keep this simple. We did a sort of a modified stopper stent, T-stenting with a blocking balloon. So the circ stent was pulled back, inflated, kissing balloon inflation was performed at that point. And then we positioned a 3.5 by 22 DES across the circ stent left main into LAD. And you see the circ wires withdrawn and used as a sepal wire to mark the the left main ostium in an interest of minimizing contrast. And then we further positioned the stent against the sepal wire. Deployed after some positioning here, ostium approximately optimized with a 4.0 NC at 18 atmospheres hanging out into the aorta. A workhorse wire was knuckled and withdrawn, circ rewired, final kissing balloon with 3.5 NC, sizing and apposition confirmed with IVUS. And then the final angio revealed excellent technical result. It looked pretty good. We had some sluggish flow in the LAD while we were working on the left main. Certainly that cleaned up with some nitro and some adenosine. And then we were able to wean the Impella in the lab. We finished the right common iliac with a 8 by 29 Viabon covered stent. We weaned the Impella, tightened down the perclose, up and over through the fresh stent, made sure that we had a tight seal, loaded with Galore at the end, and we continued the Kangol for about 4 hours. So I think, there's lots of variables here. I think there's many different right ways to do this case. But the real point here is to illustrate that the point that was made very nicely in Deepak's talk with Dr. Gibson's image, Dr. Gibson and Dr. Pinto's image, that just because the clopidogrel goes in doesn't mean it's actually doing anything. And that's even when this patient's been marinating in clopidogrel for several weeks. And so I think it was sort of a happy stroke of luck that we discovered that in time to avert any major problems. And this gentleman actually has done really well for about 7 months after this intervention. Everything went very well. So I'll stop there. Thanks so much.
Thank you, Sandeep. And to discuss this now, it's my privilege to have Dr. Gregg Stone, who is Professor of Cardiology and Population Health Sciences at Mount Sinai, and he's also Director of Academic Affairs for Mount Sinai Heart. He's been my mentor and has been a great inspiration to me in my career. I spent some time with Dr. Stone at Lenox Hill in my training almost 2 decades ago, and I'll never forget it because he's an incredible teacher and I've had the opportunity to do several cases with him, and he was very, very helpful in my career development. He's been National Principal Investigator for over 100 clinical trials, and I've authored over 2,000 manuscripts. So it's a great honor to have him here. He was supposed to get Lifetime Career Achievement Award this year at C3, but we're going to give it to him next year in 2021. So thanks, Gregg, for being with us tonight, and floor is all yours.
Well, thank you, Raj. First of all, thank you so much for that recognition. Now I've got another reason to live for another year. So hopefully we'll all be together next year back in Florida. And I'm really enjoying this session. You, Sandeep, that was a great case, and it's going to be very relevant to what I talk about. And I also, before I show my slides, I actually just wanted to clarify one thing I said in the last session, just so everyone doesn't mistake it at all. You know, with the 2B3A inhibitors, you know, it's abciximab, you can reverse, I was talking as a class, abciximab you can reverse with platelets. And that's the longer acting one, but at least it's reversible. You know, the short acting ones, relatively short acting ones, still have a biologic half-life of around 4 hours, tirofiban and eptifibatide, and those are not reversible. So you just basically got to shut them off. Even platelets will reverse them, and just wait for the concentrations to decrease. So again,
and Gregg, correct me if I'm wrong, but I don't even think ReoPro or abciximab is available anymore.
It's not. It hasn't been made for, I think it's at least a year now. So right. Some people might have some expired lots that are left, but no, and there's no generic. So you can't get abciximab anymore, which many of us believed was in many ways the most potent 2B3A, maybe the best, most compatible with renal insufficiency, et cetera, but you can't get it anymore. And that was
what people don't realize is the renal issue, right, Gregg? I mean,
right. Yeah. And that was the reversible one. So now we can't reverse the others.
Yeah, anyway. And even there with abciximab, I guess nobody needs to know this stuff anymore, but if you recall, it was promiscuous, meaning that you could give platelet transfusions.
Right.
Often would need to retransfuse with platelets again some hours later. So it was kind of tricky dealing with bleeding when abciximab was on board, actually.
It was, and for eptifibatide or ticagrelor, all you could do was try to dialyze it off if you were getting a major bleed, and we did that once and it didn't work so well. Anyway, so I'm going to actually talk vis-a-vis this last case showed, again, not an acute coronary syndrome, but very complex coronary artery disease, and is there a role for cangrelor in those patients? I think Sandeep showed you obviously a perfect role, and that's a situation where he happened to do a platelet function test after the patient had been on clopidogrel for some duration and saw that there was inadequate platelet response. So most of us consider over 208 by the Verify Now as being a high platelet reactivity. Some people might say 230, but you were in the 250s, and that's clearly hyporesponsive. But very few people are actually doing platelet function testing or genotyping to predict that. Maybe that'll change in the future, but I congratulate you for having done that. I think you probably saved a disaster for that patient by making sure that while you were transitioning to ticagrelor, that he was covered. So I've been asked to speak about the impact of cangrelor in simple and complex PCI, a look back. And I have relationships with most of the device companies, but don't have any relationships with either Chiesi or any of the platelet agent manufacturers. So everything we've talked about tonight is that to try to optimize our antiplatelets and our antithrombins according to the trade-off of preventing ischemia versus causing bleeding. And there's really no such thing as a free lunch. That's the law of Tan-Staffel. Most agents that prevent ischemia will also increase bleeding. And so you've really got to look at the individual risk factors for both ischemia and bleeding in the individual patient to determine which is more important to prevent to take the risk. A low-risk ischemia patient, but a high-risk bleeding patient, of course, you want to use a very mild agent. But on the patient that's got a high risk for ischemia, you want to use a more potent anti-ischemic agent, especially if their bleeding risk is not substantial. So there are many, many different factors that have been identified that predict either high bleeding or high ischemic risk. This is one article that we happen to write. Deepak has written them, Mike's written them, and they all basically show the same thing. Now, everybody says that often it's the same factors. The ones that predict ischemia are the ones that predict bleeding, but actually that's not really necessarily the case. So for example, the factors that predict high bleeding risk, there's a lot of unique factors, really, such as advanced age, chronic oral anticoagulant use, recent bleed, baseline anemia. Those really don't predict much in the way of ischemia risk. And then there's factors that predict high ischemia risk that don't necessarily predict high bleeding risk. And I won't go through all these in detail, but I think probably two of the most important that predict high ischemic risk uniquely are high-risk ACS, and in that regard, STEMI is a bigger risk than non-STEMI, is a bigger risk than troponin-negative stable chronic coronary syndromes, even progressive angina that's troponin-negative. And also patients undergoing complex PCI. So when assessing ischemic risk, I think the clinical presentation and lesion and PCI complexity are two of the most important factors to consider. So Deepak showed you the pivotal Champion Phoenix trial that showed in P2Y12 inhibitor naive patients, if you looked at a Kangol bolus and infusion compared to a clopidogrel loading, so basically no clopidogrel effect during the PCI because of the absorption time, you can see that there was about a 20% reduction in the composite rate of death, MI, ischemia-driven revascularization, or stent thrombosis within 48 hours. And you can see that all of this is really within the first couple hours, and this is the time of the procedure. Thereafter, you know, in the Kangol arm, you transitioned over to clopidogrel in this study, and the curves were parallel. So it's really the peri-procedural period that's the risk period in patients who are not pre-treated. And in Sandeep's case, that was essentially the case. Even though he thought the patient was pre-treated, essentially it wasn't, because there was no substantial clopidogrel effect. Now, I was impressed, and Deepak showed this slide, that when you look at all the subgroups that we examined in Champion Phoenix, we saw similar relative risk reductions with Kangol in every group. And I highlight here the stable angina, non-ST segment elevation ACS, and STEMI group, where in each of those groups, you have about a 20% relative risk reduction in terms of ischemic complications. So the absolute risk might be different. Of course, as I mentioned, the stent thrombosis rates, for example, will be highest in STEMI, intermediate in non-STEMI, and lowest in stable angina. But the relative risks will be similar. So in STEMI, I think the case is pretty clear for Kangol. You don't have time to preload with an agent. You saw the results of the Cantic trial. That was crushed Tyka. So Kangol makes perfect sense. In non-ST segment elevation ACS, if you're not going to preload for an adequate time period with Tyka, since prasugrel is not approved for preloading, if you're not going to preload adequately, let's say half a day to a day with Tyka, then Kangol makes perfect sense. But what about stable angina patients? So we wanted to look at the impact of lesion complexity. And as Deepak mentioned, we did the largest angiographic core lab analysis to date, I think, that's still ever been done from the Cardiovascular Research Foundation. And Philippe Genereux led this and spent more than a year analyzing films in 10,854 patients. And we predefined high-risk characteristics as core lab assessed long lesions greater than 20 millimeters, bifurcations with a side branch diameter stenosis of greater than 50%, eccentric lesions, thrombotic lesions, moderate to severe tortuosity, angulation, calcification, significant left main disease, or multiple lesions having to undergo PCI. And if you looked at across the board in Champion Phoenix, independent of the type of antiplatelet agent that was used, we saw a very nice graded response with the number of those high-risk features that were present and the 48 hours rates of MACE, myocardial infarction, and stent thrombosis. And I'll point out, if we look particularly at stent thrombosis, because that's the complication that we all fear the most as interventionalists, you can see if you had no high-risk features, you had a 0.2% risk of stent thrombosis, 1 in 500 within 48 hours. But as you go to 1, 2, and greater than or equal to 3 high-risk features, the risk increases. And so now you're up to with 3 or more high-risk features, you're at about 1.6% rate of stent thrombosis within 48 hours, 1 in 60 patients. So that's not trivial. And that's independent yet of randomization treatment. So this is what the MACE rates look like overall, with randomization to clopidogrel in blue versus Kangol in red, with the x-axis showing the 0, 1, 2, and greater than or equal to 3 high-risk features. And these are lesion characteristics, and this is across the board. And you can see that in the blue, that your MACE rates progressively and almost linearly increase with the number of high-risk features, and that for any number of high-risk features, Kangol will knock that rate down. And when you start to get to like 3 high-risk features, now you see within 48 hours, you've got an absolute risk reduction of around 2.3%. So you'll note the interaction effect is 0.46, it's negative. So the relative treatment effect is similar across 0 through 3 or more high-risk features, but the absolute rates, of course, will be different because the more high-risk features you have, the greater the absolute rates. Now here's stent thrombosis at 48 hours. And again, you see a negative interaction effect of p-value 0.46. But if you look here at the clopidogrel treated patients, you know, just looking at the absolute rates, here now you're up to about 2.3% stent thrombosis when you're doing PCI on a truly complex case. And that's reduced to about 1% with Kangol. And you can actually see with whether you got 1 high-risk features, 2 or 3 or more with Kangol, you're at about 1%. You don't get lower than that, but you're at about 1%. And so here with the stent thrombosis, you know, again, the higher the risk case, the more the absolute risk will be reduced with Kangol. And we looked at this in both patients with stable ischemic heart disease and acute coronary syndromes. And as I mentioned, stent thrombosis risks, now this is combining the non-ST segment and ST segment elevation, ACS. The stent thrombosis rates go up, and you can see if you look at that blue curve in the ACS, you can see how linearly they increase, and now you're up to 3.4% with ACS. And you can see when you have ACS and multiple high-risk features, now you're starting to get really big reductions with Kangol from, for example, 3 high-risk features, 3.4% to 1.8%. This is just within 48 hours. But even if you look at stable ischemic heart disease, and this is more relevant to the case that Sandeep did, his clearly would have fallen into the 3 or more high-risk features. And here you can see his 48-hour risk of stent thrombosis would have been about 1.5% and would have been knocked down a full absolute 1 percentage point down to 0.4% with Kangol as opposed to clopidogrel. And that's, of course, the clopidogrel here is, in the majority of the patients, effective clopidogrel. His patient had ineffective clopidogrel, so he probably would have had a 3 to 5, maybe even a 10% stent thrombosis rate with no effective antiplatelet agent on board. And of course, as you saw with the Kangol transitioning to Tyka, he had no stent thrombosis. And then my last slide is this, looking at the independent multivariable predictors of stent thrombosis. You can see it's the number of high-risk features. And this is independent of clinical presentation. As you go from 0 high-risk features to 1 to 2 to greater than or equal to 3, if you have even 1 high-risk feature by multivariable analysis, that really identifies a group of patients that's 4 times higher risk for stent thrombosis, then 5 times, then almost 7 times with 3 or more high-risk features. You can see, as I mentioned, stable versus ACS is also a predictor. And again, randomization to Kangol versus clopidogrel reduces stent thrombosis by 38% within 24 hours in this multivariable analysis. And that was independent of either the number of high-risk features or the clinical presentation acuity with negative interaction testing. So I think I'll stop there, but my main take-home message is that there is this interaction. ACS patients, very high risk. I think Kangol is probably appropriate in the majority of those patients, but even in stable ischemic heart disease patients, maybe what we're now calling chronic coronary syndromes, those with complex coronary disease, I think can also benefit from effective and potent platelet inhibition, especially if they haven't been effectively preloaded, and especially if they're lower risk for bleeding when there's very little downside to make sure they've got potent inhibition on board. So I'll stop there. Thank you very much.
Thanks, Greg. Very well said. You know, it absolutely goes along with both my cases and Sandeep's case. A fantastic presentation of all the data. So I'll open it up to our panel members for any further comments about the case and for any discussion about the choice of the antiplatelet drugs that Sandeep had done. And the testing of PRUs.
Yeah, I mean, I don't have anything to add to Greg's outstanding presentation. With respect to Sandeep's case, I think it was a really great case on multiple levels. I actually agree with your referring physician. I think in that frail, older patient, I would have probably gone with clopidogrel myself as someone who, you know, uses a lot of ticagrelor in general, including in older patients. There's no contraindication, but I think here he seemed kind of frail. I think I would have done the same thing they did. I think, as Greg pointed out, it's a good thing that you tested. I don't know that I necessarily would have, but I'm glad you did. And in terms of the patient's decision to decline CABG, I would have offered this guy with 3 vessel disease and, you know, impaired EF CABG too, but I'm glad he declined actually, because I'm not sure, you know, that distal LAD would have been a great target for a lima, that is further beyond where the lima would have touched down. It looked pretty severely diffusely diseased, at least as I was viewing it on my laptop. And it looked like there was a severe apical stenosis as well. So I think the real benefit of a lima might have been lost in this very old gentleman who may not realize the benefit from a lima anyway, who has not a great target in the LAD. The circ was a great target, it looked like, but even there, the distal vessels seemed kind of diffusely diseased. So I think he actually probably made the right decision.
I think those are all terrific points. You know, I'll concede that the data doesn't support routine testing, but you know, our institution is very friendly to the use of ticagrelor. We've protocolized it for our high-risk patients, recognizing that a lot of our patients are, you know, just intrinsically high risk on the basis of their risk factors, but then also it's a very ethnically diverse population. Many of the ethnic subgroups that are less likely to be responsive on the basis of reduced function CYP2C19 alleles are represented in our population. Some years ago, right when ticagrelor and prasugrel were starting to come out and were available for use, we did a sort of a snapshot of our population in terms of platelet reactivity, and indeed about 40% of our PCI patients receiving 600 of clopidogrel at the time of DES implantation, 24 hours later, shortly before discharge, met a dichotomous definition for non-response. Now, certainly 40% aren't going to go on to have stent thrombosis, but you know, our ears all sort of collectively perked up when we saw those numbers and said, gosh, you know, we're probably missing the boat on some of these folks that we're just loading with clopidogrel and sending home saying, well, you know, at least you're compliant, you're able to afford it, you're going to take it, you'll be fine. And certainly for this guy, I don't disagree with the decision either. He's the picture of frailty. Mentally, 100% intact. Actually, the primary caregiver, as I said, for another family member with a chronic condition, but physically quite frail between his CLL, his reduced DF, and a little bit of malnutrition. So, you know, I'm glad it was really just sort of an afterthought, and I'm glad we actually did it because it did inform our decision to treat him differently.
So let me reinforce what you were saying and what Deepak said, because I also agree with the decision for clopidogrel, and that's how we would have treated the patient as well. But also, as Deepak said, I don't think we would have gone necessarily the extra yard. I don't know that we would have done a Verify Now test absent some strong suspicion that he might be hyporesponsive. But in retrospect, I think this case has taught me something, because obviously it's a chronic coronary syndrome, but it was a very high-risk case. And that would have been a high-risk case for stent thrombosis. And so I think in retrospect now, or what I've learned maybe in prospect, is that kind of case, okay, go with the clopidogrel. But then I think I'd have to make sure we do the testing, whether it's genotyping or platelet function testing. And if you found out that the patient was hyporesponsive, if you had done the testing, you know, a day or two ahead of time, then you could have just preloaded them with ticagrelor or even with prasugrel, and that would have been fine. But as you did, you found out on the table, so then the appropriate thing is Kangol and then transition to ticagrelor.
I agree. I don't think a lot of people would have done that testing. It's
right
that you did.
I think, you know, I think the challenge is when you get a borderline test, right? You know, 10 years ago, Verify Now also offered a trap channel, and you would get sort of a ratio of, you know, P2Y12 ascribable platelet inhibition to maximal platelet aggregation, right? So you would have one additional piece of data. Sometimes that would confuse the picture even further, but in the borderline, you know, values, I mean, what do you do with, you know, Gregg, you alluded to 208 as the, you know, the post hoc cutoff from Gravitas. The meta-analysis data would draw the line in the sand at 230. You know, what do you do with, you know, PRUs that are in the 220s? You don't feel great going into an intervention like that with, you know, with PRUs that are sort of in that gray zone. So, you know, fortunately, he sort of fell very clearly into something that's, you know, that's not acceptable for continuing with that intervention without doing something differently.
Okay, great discussion. Thank you very much. I think that we are a little bit over time. We have a varied audience from a variety of different countries today. Some of them are in a really far time zones. There's folks here from Algeria, Argentina, Austria, Bangladesh, Canada, Chile, Colombia, Egypt, Greece, India, Indonesia, Jordan, Italy, Malaysia, Pakistan, St. Kitts, Saudi, South Africa, Sweden, UK, United Arab Emirates, and Venezuela. So good night to everyone here in the US. So thanks all our great faculty members for this wonderful session, and have a wonderful evening.
Great.
Great. Thank you.
Thank you.
Really fun.
Thank you very much. Take care.
You too. Thanks.